Good evening, everyone. Thank you for joining us tonight for tonight's panel entitled News from the Frontlines of the COVID-19 Pandemic. I am Janet Griffin. I'm the Director of Alumni Relations at NYU Myers, and we are so glad that you've joined us here tonight. This program is sponsored by the NYU Alumni Association, as well as the Undergraduate Nursing Student Organization. I also want to give a special thank you to our Dean, Eileen Sullivan-Marks, who will be joining us later tonight. This session is being recorded, and it has already begun. Before we begin, I do want to just acknowledge that we hope that you and your family are safe and well during this very unprecedented times. There's a lot of scary things going on out there, and we really appreciate you spending your precious time actually with us tonight, especially our healthcare providers who are giving up so much already. The NYU Myers Alumni Association represents about 16,000 alumni all around the world. Normally we host about 20 events throughout the year. Because of this global crisis, we've moved all of our events online. And again, we're thrilled to have you with us tonight virtually. We actually have some people from outside of the US even that are joining us too. This session is featuring faculty and alumni who are working on the front lines with COVID patients, and they're going to be sharing their experience with us about what's happening in their world, and they all work in different sections. We even have one of our panelists who's joining us from the West Coast to hear what's happening on the other side of our country. In the bottom of your screen, there is a Q&A box. If you would like to ask questions, you can just post your question there, and just let us know if you're a student, alumnus, or a faculty member. At the end of our program, we'll try to get to as many questions as possible. I know we're going to have tons, but I feel like they're also going to answer, our panelists are going to answer a lot of your questions during their remarks. Each person will, again, share a little bit about what they're doing. So I will go ahead and introduce our speakers. The first is Leon Chen. Leon, give us a little wave. This is Leon Chen. He is a double alumnus from NYU Myers and also a clinical assistant professor at Myers. Currently, he works as a nurse practitioner in the Critical Care Center of the Department of Anesthesiology and Critical Care Medicine at Memorial Sloan Kettering Cancer Center. Brian Fulsoka. Brian, give us a wave. Brian works in the emergency department in Northwell Health, Lenox Hill Hospital, and he's also a clinical assistant professor at NYU Myers. Jennifer Nahum. Hey, Jennifer. She is a DMP alumnus at Myers and also a pediatric nurse practitioner at Children's Hospital at Montefiore, and she's also a clinical assistant professor at Myers. Alyssa Raylos. Give us a wave, Alyssa. She is our panelist from the West Coast. She works in the emergency department at the University of California, San Francisco Medical Center. She also graduated with a BS from Myers in 2014. Gina Robertiello. Where's Gina? There she is. Gina is a certified emergency nurse at the Northwell Health System. She is an assistant director of simulation learning at NYU Myers. And Kristen Vasquez. Thank you, Kristen. She is an alumnus of Myers. She graduated with her BS in 2017, and she works in the cardiothoracic ICU at NYU Langone Health Center. Thank you all so much for being here. And I'm going to turn it over to you all to share what your experience has been over the last several weeks. And we're going to start with Leon, if you'll kick it off.
Hello, everybody. Thanks for joining us. Thank you, Janet, for inviting us. So as Janet mentioned, I am a nurse practitioner for Department of Anesthesiology and Critical Care Medicine at Sloan Kettering. So my department covers intensive care unit, the operating room, and also the post-anesthesia care unit. In the surge of patients during this COVID-19 pandemic, now it's one big ICU. So we usually are a 20-bed medical surgical ICU. Now I think we surge to around 60 beds. So we are covering the half the services, half the hospitals, and just as a warning up front, I do not speak for my institution. So these are just purely my opinion, my experience throughout this crisis. I've been a clinician for about 10 years, 3 years as an ER nurse and 7 years as a ICU NP. These are some of the sickest patients I've ever dealt with in my career. And one of the things that's truly, truly different about these patients is in intensive care unit in the emergency room, we all have seen death, unfortunately. But these situations where I have not seen entire families die, you know, I've seen people with their spouses just recently die, and then now they're intubated themselves, and then all without the opportunity to say goodbye to any of their family members. People get dropped off, people say goodbye at the door, and then not knowing when they're going to see their family again. So really, beyond anything else, the medical side, the human side, I think eventually is going to be the one that takes a toll on healthcare providers and also the society as a whole. So I'm looking forward to sharing some of the experience, answer some questions, and hearing from our other expert panelists.
All right, I think I'm next. This is I'm Dr. Brian Fasolka. I'm a clinical assistant professor here at NYU, but I practice per diem in the emergency room for Northwell Lenox Hill Hospital on the Upper East Side. So about me, I've been an ER nurse for 15 years now. Always worked in the ER. And this, I guess, technically is my second pandemic because I was working during the H1N1 influenza. But for, I guess for many reasons, I honestly don't really remember much about the ER from 2008 to 2009 when that was happening. And I think that's because it didn't have as significant an effect on the community like we're seeing with COVID-19. Similar to what Dr. Chen was saying, many of these individuals who present with symptoms of COVID-19 are very ill, but also Dr. Chen works in the ICU. In the ER, I also see the spectrum of severity of this, anything from minor symptoms, aches, coughs, fevers, sometimes high fevers, to severe respiratory distress and need for intubation and of course even cardiac arrest related to this. One thing that a lot of people have been commenting about if you're working in healthcare currently is the constant change. I think that's one thing I want to mention in my opening. Working in healthcare, we're used to, maybe every few months a policy change, or every year they might change a policy or they change a medication because of a supply issue. With this, we're getting, hourly changes in terms of, the PPE guidelines, operations guidelines, overflow guidelines, transfer guidelines. So it's constantly changing. And, that idea of that learning doesn't stop when you leave your institution, which I'm sure the alumni can vouch for that, but it really is something you have to stay on top of right now, because if you have a couple of days off and you go into work, there's a lot of things that have changed in the time that you weren't there. And it's not that administration is doing this. It's not that people don't know what they're doing. It's there's many different reasons for this. The virus, again, was first identified maybe in November at its earliest. We didn't have much information about this at all until the last few months, or really few weeks. So that's one of the reasons why things are changing. Of course, supply and demand has caused some changes to our practice. And I think one thing that I keep getting a lot of questions about are, what's the morale like? What's the attitude like? What are, how are the nurses feeling there? And one thing I really want to point out that, in the first couple of days that I went into work after this was, very widespread in New York City, I was a little bit anxious. I think many of my coworkers were a little bit anxious. But one thing I want to point out is that it's almost become the new normal right now, to go into, and we'll talk about this maybe a little bit later, our process of getting changed when we get there, our PPE protocols, the idea of staying in PPE for a full 12 hours, which is what we do in most areas where I'm working now. It's really just become the norm. And I don't think that maybe there's quite as much anxiety about it now among the nurses. This is just, of course, my observation. because it has just become another day at work for most of us, which, you know, in the midst of something that's of course very bad, I think that is maybe a good thing. And I actually think that the morale is very good among the staff right now, which I'm trying to identify some positive things that hopefully will come out of this horrible, you know, thing we're experiencing right now.
Okay, I think that's my turn, right?
Yeah.
Okay, great. So I'm Dr. Jennifer Nahum, and again, thank you everybody for having us here today. I think we're all honored to be a part of this profession and certainly to be on this panel for you to hear from us. And I too want to echo what Dr. Chen says. This is just my experience. I'm not speaking on behalf of my healthcare system and or NYU for that matter, but I do want to certainly share what it's like for me. I do think it's different than a lot of people. So I too have been a pediatric nurse practitioner for 11 years now. And prior to my time as a pediatric nurse practitioner, I was a neonatal nurse. And so I have never had experience in the adult world outside of nursing school until 2 weeks ago when I started to care for adult patients. So when Dr. Fuzuka said, learning will restart, it's certainly the case for me because it's completely new. And so we're super fortunate that this pandemic appears to be sparing most children. And so what does that mean? That means that everybody is not in school, they're not in the parks, and the exposures that they have lead them to just be carriers rather than actually becoming ill from this. And so our emergency department has seen a severe decrease in the amount of patients that we have. And so on average, my hospital in the Bronx sees approximately 60,000 visits a year, which if you do the math, depending on the time of year, rounds about to about 150 to 200 visits a day. Now on average, we have, and this is not an exaggeration, about 30. So 150 to 30. And so what they realize then is that we need to do something with our staff and make us more useful. And so initially they increased our age limit. So in my hospital, I'm not sure how many people are familiar with this, but the age of pediatric versus adult cutoff changes based on the hospital. So at Montefiore, that's 21. Maybe Kristen can speak to this, but I believe at NYU it's 25. Which is, I believe, also what it is at Columbia. And so we increased our age limit to the pediatric team seeing up to 30. And so that alone has been a big switch for me, not realizing beyond the pathophys of how adults are different, but just like in asking questions and doing a head-to-toe assessment as opposed to least invasive to most invasive. So that's certainly been something that I've been learning about. And also, it's interesting that Dr. Fuzuka spoke about like PPE and becoming more comfortable. So I too put on my PPE for 12 hours. I'm used to sipping, and this is not an exaggeration, 24 to 36 ounces of coffee plus water throughout the shift. And now I drink almost nothing because I don't want to take my N95 off. And so in our case, the pediatric emergency room was displaced from our emergency room, and we're seeing patients in tents, which has recently been reported by a lot of news stations, including the New York Times. And we've moved our emergency department to an outpatient floor where we don't have our normal anything available to us. And so now that all of those things are in place, our break room's further away. Is the break room really a safe place to take off our PPE? I don't know. And I don't know that anyone knows the answer to that. So as comfortable as we are getting in our PPE and like living in it, it's kind of like put it on and then live in it. So that's a difference. And then the other thing that I think is super important to mention is anyone who's in a unit that's been kind of shut down, pediatric emergency, operating rooms, outpatient settings, they're now being what we call, and I don't know how I feel about this term, but redeployed to other units. And in that case, I have now been asked to be redeployed into adult COVID units as a bedside nurse. I have not been a nurse since 2009. I've never been an adult nurse. And so fortunately for me, I work for a union hospital. And so the nursing union has put together a series of classes, kind of how to be a bedside nurse for somebody who hasn't been a bedside nurse in a while. So I think those are things talking about how we've all come together in a time of crisis. Thanks.
Hey, Alyssa, we can't hear you. No.
I can jump in while Alyssa's trying to get her sound going. So I'm Gina. I work at a hospital in Westchester County. I work in the emergency department, and I've been feeling very grateful to be able to take care of these patients. And some days you feel scared, and some days you feel sad, and some days you feel grateful. It's kind of a whirlwind of emotions. But I find that two things have come up for me, and they're two things that are always important in nursing, but I think have been more evident now. And that's teamwork. And working in the emergency department, you can guarantee you have a strong team. But I've seen it go beyond that. I mean, emergency room nurses, we notoriously have a bad relationship with everybody else in the hospital. And that's, I think Brian can relate to that. But I mean, everyone at the hospital has just been pulling to help each other and support each other in any way that we can. And that means going to different units, whether it's getting redeployed, like Jen said, or floating, or, hey, we need help proning a patient. Can somebody come up here and we need a couple hands, or you guys are short, we're overstaffed. Like, let's make moves where we can. We've been working very closely with our doctors, our infectious disease specialists. My hospital's within the Northwell Health System, and we've just been trying to support all of our other facilities. So one of our doctors, I brought a little show and tell, one of our doctors made bracelets for us, and it's kind of become our mantra. So these are them, and it says, "One team, one fight, we got this." And it's just a nice reminder that we're all there for each other and to just help each other out. The other thing I've noticed is having a coping mechanism. So Leon was talking about the toll that this takes on you, watching families die, being the only person there for them because their families can't be there. And that's kind of the burnout that we're starting to see. So just finding some tool, some way that you can process what's going on. And that's important in a time like this, and that's important always in nursing. And again, having that team support. I mean, sometimes we're our best resource. It's hard for other people to know what we're going through. So we really rely heavily on each other to listen, decompress, share our emotions, cry, whatever comes up. Those are the two things that have really been strong and clear for me. And I know those don't really answer any of your questions that were provided. So I'll let you know that we do have disposable scrubs. So we're walking around not only in our PPE, but in some extra large paper garb. So if that answers any of your questions.
Alyssa, are you back online?
Does it work now?
Yes.
Yay, I'm sorry about that. Great, everyone can hear me okay? All right. Well, sorry about that. My name is Alyssa Relos, and I graduated from NYU in 2014. I was on the traditional track. I've been an ED nurse for about 5 years now. I started off at UCLA's ED for 3, and I currently work in the adult ED at UCSF, where we've been fortunate enough to see the results of a flattened curve. I just took this from today, this morning. In San Francisco alone, we've had about 957 positive cases and 15 deaths. And we've definitely seen the benefits in our ER. Normally, we are a very busy ER day to day. We usually have we see about 200 patients per day. And I worked all weekend. This past weekend, we saw about 70 per day, which is like half of our census. And I believe California, for the most part, has really benefited from the early shelter-in-place orders. And I think it definitely brought us a very valuable resource, time. It's given us time to stock up on more PPE and ventilators, time for hospitals to create more surge plans, time to convert units and build tents to make more room for COVID-19 patients. And time has given California the ability to send 500 of our ventilators to places around the country that need them more urgently. And I'm proud to say that UCSF just sent out 20 of our doctors and 8 of our nurses to New York to work alongside NYP for 1 month. And, you know, it's really hard to be coming from NYU and coming to work in California and seeing what you guys are going through. And when UCSF had sent out the email to see who would want to volunteer to go to New York, more than 200 nurses replied back saying they wanted to come. So, I mean, right now I feel very proud to be a nurse and to be in the medical profession at this moment, because I feel like everyone's come together to really help. And we've seen a lot of support. I mean, hopefully I can give you some valuable insight on what's going on the West Coast, and I'm really excited to be on this panel. So thanks for having me, guys.
Hi guys, my name is Kristen. I am a graduate from NYU Myers 2017. I have only worked in cardiac ICU. And once Kimmel opened, our unit transferred to Kimmel, which, if anyone's not familiar with Kimmel, it's this amazing high-tech building that NYU opened about almost 2 years ago. And every room has its own ventilation system, and every room has this capability that's actually extremely valuable right now, that it can become a negative pressure room. So basically, before COVID, NYU Kimmel building had my floor, which was a 34-bedded ICU, and then they had small half-unit, quarter-unit ICUs on a couple of other floors. So we probably averaged, I would say, under 50 ICU patients in the building when we were at max capacity. Now I think we have almost 200. And because of that, NYU has responded and has hired, I don't even know how many travelers, but we just got tons of travelers in, because we were running 34-bedded ICUs with 12 nurses because we didn't have enough staff. But now it's much better and ratios are more tolerable. It's still hard. I think every day it's hard, but you have to remind yourself, which I think is something I remind myself of a lot, is that I'm seeing probably the worst 5% of COVID. So, right, like out of all of the patients that are sick, the ones that make it to the ICU, and it makes you realize that there's 95% of people that are not coming to my room, that are not on these floors. And then I do see a lot of death, but it's because it's the worst 5%. So I guess I read a couple of your questions. So some things I think I can answer would be, I have a crazy routine about what I do when I leave the hospital. I bring clothes to the hospital, I change, I put it in a washable bag because I live in New York City and I don't have a washer in my apartment, and I have a bag that I put all these washable bags with scrubs in. And it's like I have a dirty part right by my front door. That's like my dirty part of my apartment. And then I clean it with bleach all the time. I don't bring anything except for clothes to work. That's it. If I can't wash it in the washer, it doesn't come with me. Other things that I actually think almost everyone is doing this that I see at work. A couple of other questions were things that we do, interventions at NYU, which I don't know if they're doing this in other ICUs. We do have quite a lot of VV ECMOs going on right now. I think in all of those 200 patients, we might have 15 patients on VV ECMO. We've had one completely successful discharge. Patient was in the hospital. He was he was our first cannulation for VV ECMO, and he is at home. He was trached and everything, and he got decannulated from ECMO, decannulated from trach, and he's at home. He was an 18-year-old now. Yeah, right. So I guess the other thing I think I see a lot, which is, this is something I've never seen before, like maybe on my 34 bedded ICU, this would be maybe 5 of our patients, just like Leon and Gina said, like these are the sickest patients we've ever taken care of. Like you're titrating your drips, your patients are on multiple pressors, they're on paralytics, they're on all these drugs. And you also have to combine every single thing you have to do. So it makes nursing really hard, because when you have patients that are this sick, I would never even leave my patient's room. I would just be in their room all night. And now you have to think about every single thing, every single step you want to do, and put it all together, walk in your room, do your patient care, walk out, because we don't walk around donned. So every time I go into my patient's room, I have to don, and every time I come out, I have to doff. And so that is a very high burn rate of PPE, especially of gowns, which seems to be kind of right now even more shortage than masks. So I'm not sure if that answered questions or not, but yeah, hopefully I could bring something to the panel. Thank you.
Thanks, everyone. That was great. It was wonderful to hear a little bit about what all of you are doing in your corner of the world, so to speak. So like I mentioned, we have gotten quite a few questions in. Some were submitted in advance, and there's quite a few coming in during this event. So I'm going to start us off with the first question. With COVID-19, we're getting 2 divergent narratives, that the curve is flattening, but that things are also getting worse in the hospital. Is there a more nuanced understanding that can be found, and are things better, or is the flattening curve narrative just something the media is saying to make things look better?
I can take that one, I guess. So my understanding of this is, and this, one of the things you perhaps have to understand about COVID-19 is there is up to a 14-day delay in onset of symptoms. So things that are happening today are results of behaviors that occurred up to 14 days ago. So that's one thing that we have to understand when we're looking at flattening the curve, in that there is going to be a significant delay. And some people have, not to sound weird, but some people have used the term perfect virus to describe this virus, because that delay is one of the reasons that this virus is so problematic, in that you get exposed and then there's such a long delay before you know that you're contagious and that you're spreading this virus to other individuals. So we have to be careful when we look at the numbers here. What you are hearing about, the hospitals being very full and having many acutely ill patients, yeah, my understanding, that is very true at every hospital in New York City, particularly in like the Bronx, Queens, and Brooklyn, where they're actually transferring a lot of patients to the hospitals in Manhattan to help support those outside hospitals in the boroughs. When you're looking at flattening the curve, though, it's also this idea taking into account deaths that are occurring. So when we're talking about the number of hospitalizations decreasing, part of that is because there were a lot of deaths, and now those are individuals who are no longer counted in the numbers of being hospitalized. So yeah, that's why we're seeing, yes, we are seeing some benefits to this. However, part of that is related to the fact that there were deaths, and that again is helping the health system from not being completely overwhelmed, because when someone does die, unfortunately, the only benefit that you could possibly say out of that is that it does create another ICU bed for another individual who can then be placed in that room.
Yeah, go ahead, Leon.
Oh, okay. So I just want to add on to that. It's very true. So first of all, I think the overall stats, flattening the curve, each individual state is a little bit different. So, and then I will go with the official, what Dr. Fauci talks about, and then individual governor talks about their, various curves in the state. Remember, our curve here in New York is not going to be the same curve in California based on the social distancing, how tightly they control, shut down businesses, how tight they enforce all these social distancing rules. So the curve is going to be different. So obviously right now New York seems to be plateauing and flattening out a little bit because you're seeing some of the policies work, but that's just one state. There are other parts of the country that is actually just ramping up right now, and then they're going to be lagging behind New York, lagging behind California and some of the New Jersey, some of the states that's taking a big hit right now. So that's one thing. So it's not an overall entire country curve. Another thing is that part of that curve is not only just people who are infected. There's a line where all the hospital resources are stretched. And we're definitely seeing hospital resources being stretched right now, both from my personal anecdotal experience and then from colleagues that are working in different hospitals. Overall admission to the hospitals might be a little bit decreased, and you can see that, for some reason you're going to see, or not for some reason, I have a pretty good idea why, but you're going to see less cases of MIs, strokes, not because they're not happening, because people are writing it out at home. And also, since all the city highways, there's no traffic, so there's less accident, less trauma in general. So the admission for other of those cases are decreasing. But in critical care resources, that's being stretched. There are only so many critical care providers in one hospital. There's only so many ICU beds in some hospital. There are only so many critical care trained nurses in one hospital. And that's why you see all the redeployment of non-critical care clinicians into the critical care area. So that I feel like it's gonna take a while to kind of flatten out. And then unfortunately, as we see the plateau and also flattening out a little bit and maybe down the curve, the death rate will continue to be at where it's at, maybe increase, because remember the first wave of patients who are sick enough to get hospitalized were on a ventilator. On average, if you look at the data, they are on average intubated for around 2 weeks before you can see if they're getting better or worse. So for the people who are not getting any better after 2 weeks, they will die. And then the death rate, so death rate might go up for a while, and then you're going to see two different curves ultimately. Mm-hmm. So I do think the policies are working, especially in the states that are very strict about it. But I am a little bit worried about, without going to like policies and overall public health and politics, I do think there are other states that I'm a little bit more worried about, that they will have a spike in the hospitalization and infection rate.
Yeah, go ahead, Jennifer.
I just want to note that I also think we're going to have I think we would probably all agree, we're probably going to have a secondary spike here if we're not very attentive to keeping the social distance. I know that personally, like once this ban is lifted, I've already spoken about like, what can I do to have like a little party for my daughter who's been sitting home alone, with us. But I know that that's going to have to wait a very long time. And I think that I hope that the rest of the community is aware of that also, so that we don't have that dip and then secondary spike here in the tri-state area.
Another question from a student, and this is a great segue. They were asking about this very same thing about round 2 of COVID cases, and would you think it would be more widespread than round 1? Go ahead, Leon.
So the scary thing about this, and I can't imagine, because I'll be honest, when it first came out, like with the first reported cases back in November and December in China, where they talk about clinicians with like they're starting to see these weird, unusual, atypical pneumonia and respiratory failures, and then they're not 100% sure what caused it. And at first, at that point, I actually just was thinking to myself, how unusual could it be? We've dealt with regular coronavirus, we dealt with influenza, we dealt with multiple viral infections. How could they say this is so different from what they have seen in the past? And until we actually actually deal with the coronavirus, COVID-19, and then they are very, very recognizable. There are a lot of characteristic features now that I see, oh, okay, we could diagnose COVID-19, swab positive or negative, so the first group of people I give a lot of credit to, that they actually recognize that this is something completely different. But with that being said, what we know about COVID-19 is so limited right now. There are tons of research out, there are tons of papers out. If Dr. Fasalka is a PhD with understanding in research method, I'm sure if he was reviewing a lot of papers, he would question a lot of these research methodologies and how good they are right now. So what I'm trying to say is we don't know much about it in terms of are you able to get reinfected? Do you generate enough immunity to even have to decrease reinfection? We don't know. So the secondary infection, for all we know, could be worse. I don't know for sure. But if some of those limited data, like things that says we don't generate enough immunity, we don't generate enough antibodies, if that's the case, then I would say secondary infection, the second wave might be a little bit more scary. The only thing that's good about it is we dealt with it once, so we kind of like the first wave, maybe we'll handle it better, in terms of that the protocols that we use might be used for the second wave. So we're not getting hit as blindly as the first wave. That's the only thing that I would say maybe will be a little bit better. But unfortunately right now, not a lot of definitive answers out there.
Great, thanks. We touched on this a little bit in some of your opening remarks as well, but are there any treatments or interventions that you have seen that are really working with the COVID-19 patients? Go ahead, Gina.
So we've been proning patients, and that seems to be helping. So proning meaning, usually you're laying on your back, flipping them to lay on their chest. And it kind of helps with like the redistribution of fluid in the lungs and the alveoli. And we noticed it was improving in the intubated patients. It was helping them. So we started doing it before patients were getting intubated. And it's so far looking like it's helping to prevent that. And then there's other things you can do, like changing the position of the arms, swimming the arms when they're in the prone position. So that sounds like something simple you can do, but once a patient is intubated, it takes a whole team to do that. And so some of the hospitals have come up with some creative ways of doing that by having proning teams or like a proning cart. But that's one thing that's been pretty effective as they try to figure out the drug regimen, because there is some research going on with drugs and trials, but I couldn't confidently say that any of the drugs are really working reliably right now, just because, like we said, the research is so young that it's hard to say. So proning seems to help.
Great.
This is entirely just one case report from one individual I know who was hospitalized with this. And this person was not intubated. But in addition to the positioning, like proning, she reported that chest PT significantly helped her breathing. And again, this was one person, so one case report we're looking at here. But so as far as the medicines, though, I could not comment that any of the medicines are, appear to be working. But again, I don't see patients on the long-term basis. I see them in the emergency room, and usually I give them their first dose, and then hopefully they get moved to an inpatient area before they're even due for their second dose of those medicines.
Great. Oh yeah, go ahead, Kristen.
So we do proning, but sometimes patients can't tolerate proning. So I've been doing, which honestly, I have no clue the benefit this is giving patients, but I feel like it's better than not doing anything when they can't tolerate it. Our ICU beds do continual lateral rotation. So it does basically lung over lung therapy. And your bed's like this, right? And so you could have your patient like this for 10 minutes and then go back down for 5 and then go back up for 10. And most people, when they see this therapy on the bed, they think that it's a skin therapy. It's kind of controversial if it actually provides offloading, but it's actually made for lung over lung therapy. So I've been putting all of my patients on lung over lung therapy.
Got it. Go ahead, Leah.
So in terms of drug therapies, it's I agree. I don't think there's good data on any drug out there. The Infectious Disease Society of America just published a guideline only like yesterday, the day before, addressing all of the therapies, the drug therapies, including things like hydroxychloroquine and some of the other ones that is reported in the news a lot. They essentially said it's clinician, provider, collaborating with infectious disease specialists in the context of clinical trials. They listed everything that we're giving to people in the context of clinical trials. So is there anything that there's a magic bullet, so to speak, in terms of drugs? I don't think so. The targeted for the actual COVID-19, I don't think we have a single one that's the magic bullet. Now, in terms of supportive care, what critical care does, there are a lot that we do see kind of help. Gina mentioned the proning. It's one thing that we've noticed it helped. If you go to Society of Critical Care Medicine, if you go to American College of Chest Physicians guideline for COVID-19, you could see a list of supportive therapies that probably, in expert opinion, and people who dealt with ARDS for years and years know that works. Proning, low tidal ventilation, high peak method for some subset of patients, steroids early on, paralytics, improving work of breathing, all those things that we do for usual ARDS. And then with one or two caveats that specifically to some of the phenomena we see with COVID, like the overwhelming inflammatory markers like IL-6, the cytokine storm, and then the coagulopathy or the hypercoagulopathy that we see in dimer. So all of those therapies, it's a very interesting time to be practicing like in critical care. So I just see one question that in the Q&A said, do we ever like regret going to this field? I would say absolutely not. I feel bad for my family members, and I worry for my family members that I don't want to expose them, get them sick. I do fear for my well-being sometimes because I want to be there for my family. But do I regret going to this? I went into critical care for like a reason. So even though this is a horrible pandemic, a very, very small like little part of me, for people in critical care and emergency room, this is a very exciting time at the same time. We're dealing with something that we've never dealt with, where evidence is building on a daily basis. And then we are like doing the best we can with whatever we have. So, if that's what you're into, if that's something that excites you, I encourage you to continue on your path to become a clinician and help us battle this pandemic and the possible next pandemic, unfortunately.
So we've gotten a lot of questions about how you are interacting with your family members, or in general, and in particular, people that you are living with, and the precautions that you're taking in order to not spread any possible germs to your family. I know you've talked a little bit about your routine, about clothes washing and things like that, but what are you doing interpersonally to not spread this virus? Yeah, go ahead, Jennifer.
So I'm fortunate that I live very close to a lot of my family. So I live with my husband and my toddler, and then our parents all live nearby also. And my husband's fortunate to have a job where he can be working from home. So we are doing what we ask everybody else to do, which is socially isolating. My husband and my toddler don't leave the house except to go to the backyard or for a walk around town. Where when we walk, we don't walk on the same sidewalk as everybody. I live in the suburbs, so that's much easier to do than it is in New York City. So I feel fortunate for that. We are not seeing parents. We're doing a lot of FaceTime, and I am considered like the dirty person in the family. So I'm the one who goes out for the groceries, and I'm very proud of myself. So far I'm going every 3 weeks. And really just like stretching and being creative about the food. When I come home from work, I do what my colleagues here have mentioned, which is I bring a bag of clean clothes, and at the last exit before I leave the hospital, I take off my contaminated clothes and I put them in a bag. And then I walk out of the hospital and I wash my hands, and then I remove my mask, and before I get in the car, I take off my dirty shoes and I put those in the trunk in a bag, and I put on my clean shoes to try and do everything. And then I have Clorox wipes in the car because although I thought I cleaned myself as good as I can, I wipe down the car before when I get in and then when I get out again. And then I come home, and again, living in the suburbs, so I don't have the same problem as New York City dwellers. I have a washer and dryer, and I bring my scrubs upstairs and they go right in the wash. And then the clothes that I just wore for the 30-minute drive home go in the wash with those, and they go on hot. And then I go into the shower, and then I go downstairs and say hi to the family. Knowing that I could still be exposed, but leaving my N95 mask on for 12 hours straight and not eating, drinking, or peeing hopefully has limited my exposure and therefore saved the exposure to my family as well.
Go ahead, Alyssa.
I do basically do everything along those same lines. We're lucky enough at UCSF, they've given us scrubs to change into at work. So I use my usual scrubs, and I'm lucky enough that I can also drive to work and have a parking spot, as opposed to like New York where you guys have to take subways and transportation. So I just wear my normal clothes to work. Once I get there, I grab a pair of scrubs, I change over there, and I put everything in a bag in my locker. I'm also lucky enough to have a locker so I can put my shoes and keep my work shoes at work and never bring them home. I go about my day, my 12-hour shift, when I'm done, I change out of those scrubs and put them into the hospital's laundry, and then basically drive home. But once I get home, once I get inside, I take off everything, put them all in a bag, and just hop in the shower right away. Don't even say hi to anyone. And once I do that, I literally wipe down everything. I wipe down the doorknob, my cell phone, my badge, like anything that I brought back in with me into the house.
I'm sorry, I want to add, my cell phone goes in a plastic sandwich bag. And your phone will still work. You can still hear people, so I wonder how permeable it is. But so my phone goes in a plastic sandwich bag, and I'm not normally this wasteful. And then that gets wiped down, and then the phone gets wiped down as I take that out, and the plastic bag goes in the trash.
Yeah.
So things coming with me, again, like my colleague said, are my scrubs, my phone, and my car keys.
Mm-hmm. Yep. Yeah, your phone is probably the dirtiest thing that you carry, to be honest. And then when I'm home, I live with my fiance and one of our roommates, but I haven't, my mom, she's a bit older. She lives down in San Jose. I haven't seen her since this all started about a month ago. So a lot of FaceTime, haven't seen anyone besides the people that I live with. And even then, for like the first couple of weeks, my fiance was sleeping on the couch, to be honest. So that's how we've been kind of social distancing in our own way.
I'm in a little bit of like a unique situation. Dr. Fasaka knows because we teach classes together, so I talked about this. I have not seen my wife or a baby for about a month now. So they are, I know, Jen, this is a tearjerker, I know. So when New York reported its first case, I kind of had an inkling that, in the intensive care unit, it's gonna hit all of us. And then honestly, even though from what we could tell, it doesn't affect kids as severely, but honestly, this is such a new disease that I don't know what the long-term effect is. I don't know what the long-term effect on kids who have it, or I feel bad for my colleagues who are pregnant. We don't know what the long-term effect on fetus is going to be. So to be safe, I asked my wife and kid to live with my in-laws in Long Island. So just to kind of be completely separated from me. So because I am the dirty one, and I'm the one who is gonna get exposed if anything. So I don't want to expose it because I signed up for this. Our family members did not sign up for this, so I don't want to do that to them. Another thing is, remember, like my parents and my in-laws, they are older. They have comorbidities. Chances are, honestly, if God forbid I get it, I like my odds compared to my in-laws. Although to be fair, my diet is probably worse than theirs, so maybe I do have a lot of comorbidities that. Yeah. So I think if anything, I signed up for this, and I don't want to expose them. So in terms of my cleaning routine, I do live in an apartment, so I don't have a garage or anything like that I could dump dirty stuff in. I heard a lot of colleagues, they literally strip in front of their house, flashing the entire neighborhood before they go into the house. They don't even care. All right, special circumstances. But I have a hamper that's just for scrubs. That's separate from like regular clothing, and then that sits right in front of the foyer area. And then there kind of is an area that I refuse to cross over if I have anything on. And then I take off my shoes. I have Lysol wipes, and I have like a Lysol spray that spray down my shoes. I do have separate shoes that I wear only at the hospital. I have scrubs changing to just at the hospital. And then I spray down everything. I spray down the floor. And then I have alcohol pads like right on this table in front of the foyer. I wipe down all the phone, like my ID, put it down. I have like Purell for my hand afterwards, after I take everything off into the hamper, spray down the area, and then go straight to shower before I go into the decontaminated area of the apartment. So, if you told me that this is what I was going to be doing like three months ago, I would be like, what kind of crazy person do you think I am? But like my wife was like that to begin with, but now I've officially turned into that crazy person I made fun of. So yeah.
What a regiment all of you are doing every single day. You're coming from the hospital. That's amazing. Another question that we've got several people that have asked is just curious to know if the Comfort or the Javits Center Hospital have helped reduce the loads at your hospitals for patients.
So we just started transferring patients to Javits Center in the last week, but one of the problems I'm observing with the Javits Center, and I can't speak to the Comfort, but I believe that they have similar criteria. The criteria to transfer a patient there is extremely stringent. And again, this is not me speaking from my hospital, this is my opinion, but patients who would meet many of the criteria or all of the criteria they expect to transfer there probably could go home because they have to be able to walk, is my understanding. They have to have a pulse ox of 94% or higher. We have to send them with 5 days worth of medications to go there. So while I guess I'm just somewhat frustrated with the field hospitals. Again, this is my opinion, not speaking for my institution, but I just would feel like a military hospital that can set up anywhere in the world and care for the most extreme trauma patients or critical care services that are supposed to be at the highest level in the world. I'm surprised that they expect their patients to be able to walk and have a pulse ox of 94% or higher. So that's, again, my opinion on that. So I know they have patients there, and I know that they are assisting, but I'm surprised that they are, maybe Jennifer, maybe you have some input from your institution as well. I'm surprised that they are not taking a larger bulk of the patients. I thought they would be accepting more.
I actually don't have anything to add because I've still only seen up to 30. And as the nurse practitioner, when I've been seeing those adults, they've given me the lower acuity ones. So just ones that generally speaking could be seen, teaching provided and discharged. And if they needed to be admitted, they'd be sent inside to the hospital for admission right away.
Got it. Another question we're hearing a lot of is, how often are frontline healthcare workers being tested for COVID-19, and are there any plans for future testing? Sure, Kristen.
So at NYU, as long as I think every institution's different. So at NYU, as long as you're exposed to COVID as an employee, you can be tested whenever you want. So you just have to be taking care of COVID patients. That's it.
Anybody else? How about it? Yeah, Leon?
Yeah, so it's, as Kristen said, this is institutional specific. I know colleagues from other institutions that, they had the exposure and concerning symptoms, and then the availability of tests was not there. So my institution, I've been pretty lucky that we do have testing, and then employees are being taken care of in that regard. If you have exposure and then you have kind of concerning symptoms, you are able to be swabbed. And I have actually been swabbed a couple of times because of exposure, and also just a little bit of worrying symptoms. So and luckily been negative, but yeah. So but I think that's institutional dependent, at least at this point.
Yeah.
I think one of the terms, we use the term exposed a lot in the discussion there, and different institutions are using different criteria for what's considered exposed. So what I'm hearing that a lot of institutions, from speaking to other colleagues though, they only consider you exposed if you were in the room and not wearing your PPE. So if you're in the room and you're wearing everything proper, you're not considered an exposure.
Got it. Alyssa, did you want to say something?
Yeah, and I just want to say as a disclaimer, I don't speak on behalf of UCSF, but we, we were kind of, as a whole, Bay Area was bit slow on the uptake of testing. I feel like New York is testing way more people than California is, just in general. But as for testing employees, every morning before we go into work, we have to get into a line to be screened. And basically we just answer the basic questions. Have you been exposed? Have you traveled from New York in the past 14 days? Do you have any of these symptoms in the past 24 or 14 days, or 24 hours, 14 days? And if you mark yes to anything, then you cannot go into work. You cannot even enter the hospital building. And then occupational health will follow up with you and give you a call and set you up an appointment, a telehealth appointment, just to assess your symptoms. And then based on that, they will schedule you to go get tested, which is what happened to me, because like a couple of weeks ago, I started having a sore throat, headache, body aches, no fever though, no cough. But I didn't go into work. Occupational health called me, and then they were like, okay, great. Can you go into one of the sites and get tested in the next 30 minutes? I was like, yeah, great, let's do it. So, I mean, I think UCSF has done a good job about doing that, but again, it's only if you're showing symptoms.
Go ahead, Leon.
So yeah, same thing in terms of exposure. I completely agree, and also I just think what we are understanding about this condition is just in terms of how it spreads. It's obviously evolved a lot since it first came out. In terms of where it was droplet and airborne. First of all, I gotta say all the bedside nurses are beyond, like, I think it really just they should get as much credit as there is, but because honestly, as MPs like me and Dr. Nahum, we do see patients, but like limited amount of time. And then the longest time I spend in a patient's room is when I'm doing procedures, invasive procedures. And then so I'm there for half an hour. They're doing the intubation process, inserting like invasive catheters and things like that. So that would be our exposure. But nurses, bedside nurses, they're in there for hours and hours, and we've been trying to help out in terms of decreasing the unnecessary amount of finger sticks, let's say, IV dosing medication, like spread it out, one-time dose, like on a 24-hour dose. We've been doing as much as we can to not expose the bedside nurses as much as possible, but I can see that the nurses obviously gone into this for calling in a sense, and then I've seen, agitated patients, clearly, we know COVID positive, and then, coughing, not intubated, and then they're completely alone, they're scared, and I've seen nurses in there for hours just kind of holding their hands, like literally just sitting there in their gown, in their PPE, and in a potentially aerosolized room, like just holding the patient's hand for hours at a time. So, honestly, that those kind of things, and if that person, even though it's not an aerosolized procedure, she's not intubating anybody, the high risk aerosolizing procedures, if a nurse like that next day have even a sore throat, I would immediately recommend them to get swabbed, and because the exposure, we know the viral load is correlated with how sick people get, and then we're all exposed, and one way or another, some more than others.
Yeah. Go ahead, Kristen.
At NYU, something we did to, speaking on what Leon said, to decrease our exposure as bedside nurses, was we have made extension tubing on all of our pumps, and we turned our patients' beds so we could see them. We have glass doors outside of our ICU rooms, so our patients facing the ICU, we could see the monitor, and all of their pumps are outside. So we could hang piggybacks, we could titrate drips, we could do all of these things without actually physically going inside the room. And we actually have a couple of vents there that we could even make vent changes outside of the room without even going in, because the top of the vent is detachable from the base of the vent, and it's a cable that runs. And so like we have it outside of the room as well. So we're trying very hard, but it's right, it's true, like you're exposed. Last time I worked was Saturday night, and I was helping a nurse, and we were doing patient care, and we were turning her patients intubated, and we broke the circuit 3 times. And it was just, everything is positioned odd, and it's just 2 of us in this room, and we're turning this woman, and it just happened. Unfortunately 3 times. And then I started freaking out after, but I had my gear on. So it's like, okay, I'll be okay. You have to tell yourself that. And then you also, which I don't know how Jennifer and Brian do this with wearing their mask for 12 straight hours. Cause I feel like eventually I feel like I'm getting the COVID symptoms just from having my N95 mask on for an hour straight, because your throat gets so dry and you feel like, oh God, am I getting a sore throat? Or is it that I've just been basically poisoning myself with my own CO2 for the last 2 hours? So it's hard. I think it's very mentally taxing on yourself too, because you have to keep reminding yourself that you know, like this is what I do. I want to be in the room. I love my job. I would never change it. But at the same time, you know, we're putting our lives at risk. So it's really good when providers like Leon and realize that, and they really try to help us out. And I personally really believe that, I hope every hospital is like that. And NYU has been amazing with that and trying to really decrease the amount of time we have to go in the room. And we're not even allowed to be in the room for intubations. We have an intubation team. It's not even the primary team that comes around and intubates patients. We have a proning team, so the nurse shouldn't be in there when we prone our patients. And it's certain things like that that I think could actually decrease the amount of time we're in the room, because we have to be in the room for everything else.
Yeah, I just want to add, so even though Dr. Fasalka and I teach pharm, and we always emphasize that the enteric route is the best route, not in this time. Everything that, you know, all the IV pumps are outside and we know it decreases exposure. Sorry, everything is going through the IV. And I tell the bedside nurse, I do not go in there unless you have to, and then, you know, and cluster everything together. So the providers I've been talking to my team, they have to be very cognizant of how many times the nurses have to go in there. So do not order a lab this hour and then another one 10 minutes later. And then, you know, it just, that makes no sense. Group everything together. And then honestly, I wouldn't ask the nurse to go into a room that I wouldn't go into. So very, very important. And I do wear my N95 all the time because we respond to the critical care team respond to rapid responses and medical codes throughout the hospital. So there's, you know, the shorter time I could don everything, the better. So I do have an N95 on all the time.
We've gotten a lot of new grads that are very curious on what it's going to be like to enter the job market in a pandemic, or hopefully what would be the tail end of a pandemic. We have a lot of students that joined us tonight, and so would love to hear your thoughts on that as well.
I can take a stab at this one, but I don't think any of us can actually give none of us can give a solid answer to that. You know, this could go two ways. It could be, hey, we really need nurses, so we're just going to, but we're going to hire many new grads and quickly get them on board and orient them. It could also go the opposite spectrum, though, that they might say, we don't have the resources with the nursing education division and human resources and you know, to get the residencies up and running and do a 6-month orientation or a 9-month orientation or however long they run it. So that one could really go either way. I don't know which way it could go. Do I still think there's going to be job opportunities? Absolutely. It just might look different. The orientation process might look different. They may not run maybe some of the specialty, like 1-year orientations. Again, this is just me thinking out loud right now, but none of us really know how this is going to impact the job market on a long-term basis. Right now, we're kind of in this crisis mode where there was, you know, a couple days to weeks notice that, hey, you have to get ready for this surge. So the major response was looking for recently retired nurses to come back to the market, and also a lot of travelers were brought in from other areas of the country. So there are literally thousands and thousands of traveler nurses in the tri-state area working right now. Again, that is very financially costly on health systems, and you know, that's just a known fact. I'm not sure, you know, where we'll go from here, though. We're still, everything, again, as we mentioned, is kind of changing hour by hour. So how this affects finances, job market, hiring processes in months to come, I don't think any of us really know.
And if you're if you're a new grad entering the field of nursing, just don't be afraid to advocate for more time on orientation. If you're like, oh my gosh, I'm not ready to be on my own, I need another week, I need another 2 weeks, it's okay to ask for that, and new grads often do. And it's totally, you got to listen to yourself and listen to if you're ready and you feel comfortable and confident.
As Dr. Fasalka mentioned, I don't think anybody know what the job market is going to be long term, and then I think there are a lot of people who are smarter than me, like working on these type of issues. But I see it as one or two things. There are a lot of, first, the bad thing, all right, and nothing I'm saying right now is not reported in New York Times and other major presses, so you could see. I think there's going to be a lot of opening after this pandemic, because a lot of people working frontline right now are going to develop PTSD, just burnout, all those things that we've been worried about even before pandemic within healthcare. And then probably after this is just compounded exponentially because of all the stressors and just seeing all these tragic cases. And then there will be a lot of people, leaving. And then and another thing is people who enter the job market or in school right now, we would like to think every single person who entered medical school or nursing school are doing it because they feel a strong urge to help people, the calling to, to help the needy and the sick and the ill, to want to heal. But there's always a small percentage of people who enter the school because, it's a stable job. It's a relatively well-paying job. And then, before this, they saw it as, we're not putting ourselves in personal danger, not the way, police officers and FDNY, they don't think about the danger that we're in. So this will actually make some people who never thought about that, whether or not this job was worth it, worth the personal danger, to drop out. So I think a good portion of people will leave school, and then there will be a demand for the people who are ready to accept this reality and want to step up and to fill in those openings. So I think it will be very interesting to see. So, but ultimately, this is just me thinking out loud. Like, I have no actual answer for this.
We've also gotten a lot of questions about PPE, and I know we've talked a lot about PPE, but people wondering, the hospitals are they taking these donations? Are they getting to the right place? Are you having to reuse PPE? How safe is it? So if you could just address, what your hospital stance is on that, or your opinion. Go ahead, Jennifer.
Yeah, like I said, initially, and this is weeks ago, I think they were concerned about the amount of PPE we had, and that's why they were a little bit reserved about how many masks we should have. But there don't seem to be these limitations as they were earlier, and maybe that is because we got more, or maybe more came in. I'm really not sure about the logic behind it, but we get an N95 mask handed to us as we walk in the door, so that's 1 per 12-hour shift, which I can't speak to anyone else, but seems adequate to me. Like, I feel comfortable in that. And then if we see a COVID positive patient, we are given more gowns. We normally get like 1 gown at the beginning, but if we have a COVID positive patient, we are able to change out and get a new gown also. They give us enough surgical masks that a surgical mask goes over your N95. So again, if you have a COVID positive patient, you change your surgical mask over that, and then you have your N95 under. And I haven't felt the need to, but I'm fairly certain, as I understand it, that if I said, I feel like my mask is contaminated, that they would give me another one without any issues. So I don't know how that's come about or who has, done that for us, but I'm appreciative of it. And I think at least I can't speak to the whole hospital system or anybody other than me, but I might also speak that it seems like from what I've seen in my coworkers, we feel like we've had the appropriate protection, even though sometimes you wonder if that's enough. Like Kristen was saying, like even when you're totally gowned, you're like, did I somehow still get exposed?
Yeah. Also, several questions have come up about just a nurse's mental health. Leon, you touched on this just a moment ago. And, you know, what are things that all of you are doing just to keep your mental health in check, and you work-life balance, or, you know, things that your colleagues are doing, or your hospital is doing to help manage just all the nurses' anxiety through this hard time? Go ahead, Kristen.
So I started seeing a therapist. I highly recommend it. I think we all should. I think that no matter what you could ever imagine in your life, especially, I can't say that if we would see more death in the ICU than the ER, because I've never worked in the ER, but we're seeing a lot of death in the ICUs. And it's sad, you know, like to see someone die alone is very sad. I exercise. I try to eat extremely healthy, which is very boring when I'm not at work, because like I feel like it's going to make me more mentally healthy. And another thing we did, which I actually think, speaking of morale on units, is we started a food list, and all of our nurses have reached out or posted somewhere and are working on getting donations. And we try to get on our unit breakfast, lunch, and dinner donated. And so we have like an Excel spreadsheet so everyone can see what's been donated. And then that way we also don't have to worry about eating. And people's responses have been incredible. They want to help, they want to feed us. And it's really nice. Like they write us these little notes, or last time I worked, a patient's family at 3 a.m. surprised us with 20 iced coffees, which was much needed at 3 a.m. So I think that any way that you can increase morale in the unit is a great thing. And I think also exercise, understanding the importance of seeing someone and getting help, even now before it's over. And I think a lot of people in my unit are doing the same.
Go ahead, Alyssa.
Basically everything that Kristen said. Just your mental health is so important, especially during this time. I just remember a month ago when all of this started, it was just really a lot of anxiety, and UCSF has offered therapy sessions for employees, and I know a lot of my fellow employees also took up on that. And I've been to 4 sessions myself through telehealth, and they've been really helpful. So just kind of checking in with yourself and knowing when you feel like you're overwhelmed, and if you need that, you know, just like a little extra guidance, you just reach out, try to get therapy if you can. Also, some cool things that have been going on. I think 10% Happier, which is a meditation app. They're giving 6 months free unlimited to healthcare workers. So if you want to reach out to them, they'll give it to you. A lot of other apps, like I think Down Dog, which is a yoga one, is also giving like unlimited monthly subscription to healthcare workers as well. I think everyone collectively within the hospital and like normal citizens recognize that this is a very stressful moment for everyone, but especially for healthcare workers. So people have been reaching out a lot. Going back to the food thing, UCSF, one of the nurses over at Mission Bay, she started organizing a fund, and she was getting donations from money to put into this fund, and she's been giving it to smaller restaurants out in the community to help keep them open. And that way we in the ER, we've been getting food delivered to us for breakfast, lunch, and dinner through this fund, and also gives back to the community and helps keep these restaurants open. So just collectively as a community, if you like reach out, people will help you, you know, and just recognizing when you do need help, just checking in with yourself. And honestly, on my days off, I play Animal Crossing. So that's my de-stressor too.
Go ahead, Leon.
So I think as Kristen said, it is, and Alyssa said, this is a like unprecedented time. So I think there should not be any stigma whatsoever if you need to have talk to a therapist, or I know there are some people who like still don't like kind of don't want to go admit that they do see therapy, they do seek help through this time. I think this is, if any time is time to like remove any type of stigma for that, this is the time to do it. So my institution does help us, like give us access to therapy and mental health, counseling, and all of that is covered by our psychiatry department. I think there are other apps that's free for healthcare workers, or at least for a limited amount of time. And I think if you need it, this is the time to utilize it. Me personally, I have not utilized it yet, but I wouldn't be surprised if I end up needing it, because we're having very, very hard time seeing these like patients. Just the other day, I had to like talk to a person who was on the verge of intubation, encouraging them to talk to the family on FaceTime. And then he was like a 9/11 volunteer. It's just very, very sad. And then it will weigh on everybody at some point, no matter how much, how strong you are, or so to speak, and how much of it you could just compartmentalize and brush things off. Unfortunately, again, according to like Washington Post and things, you might see a surge in substance abuse for healthcare providers, like alcohol dependency. For me, I've gone to these things. It's just water. Don't worry, it's just seltzer water. But I encourage everybody use appropriate resources, exercise, and seek professional help to get through this time. Like this is a trying time, and I do see some positivity that the teamwork, the support from other groups, donating food and donating PPEs. So those are some of the silver linings and the positive things that I see right now.
That's great. Thank you. Well, we just have a few minutes left, and we've had so many questions. I've tried to get to as many as possible. But I just wanted to see if, for our speakers, if there's any final thing that you wanted to share that you would just like to share with everybody who's in attendance tonight. Go ahead, Jennifer.
You all may have seen or heard about this, and I actually haven't been to work since this has been implemented, but apparently some hospitals, when COVID patients are either extubated or discharged, have been playing Here Comes the Sun by the Beatles. You heard? Well, FYI, and this is secondhand information, but in the Bronx, we play Empire State of Mind. So if you like listen to that song and like just feel like all like the New York energy, apparently everybody says it really like makes them feel a lot better when they hear that song and they know that all their work is going to a good cause.
I personally would advocate for New York as a Yankees fan myself. So that's just me.
That's great. Well, that was a great story to end on too. So thank you all so much for spending your evening with us. I just really appreciate you giving us, just really peeling back the veil, so to speak, so that we can see what your life is like on a regular basis. And it's right now pretty challenging, but I love hearing that you love the challenge and that you're in it and you are for this challenge. So thank you for your commitment to your colleagues and to your patients, to your family members who are also making the sacrifice. That goes for all the healthcare providers that are on the line with us tonight. I know a lot of people had tuned in. So our next event will be Wednesday, April 29th at 6 p.m. Dr. Robin Clark will be discussing lessons learned from the Ebola outbreak in West Africa and how these lessons can inform nurses during the COVID-19 pandemic. So hopefully you can join us for that. Again, thank you so much. And everybody stay safe and healthy and have a great night.